Today, we're excited to host Dr. Duncan Lascelles. This seminar is part of the speaker seminar on diseases familiar to humans and animals. This is made possible through an endowment from Dr. George Krienke, class of 1961. And while George is unfortunately unable to attend today, we're very pleased to have Dr. Tim Krienke here on his behalf. Thank you for being here, Tim. And please pass along our sincere gratitude to George for his generosity and for his vision in supporting this. We also want to gratefully acknowledge the University of Minnesota Pain Consortium and the Pain Interest Group for their partnership in making this seminar possible today. Dr. Lascelles is a professor at North Carolina State University College of Veterinary Medicine and is hosted today by Dr. Alonso Guedes. He'll provide more information and a detailed background. I'll pass it on to Dr. Guedes now.
Wonderful. Thank you, Amy. Hi, everybody. It's my pleasure to introduce to you Dr. Duncan Lascelles. That comes to us from NC State University, where he is a professor, as well as a distinguished professor, distinguished professor of musculoskeletal health, as well as director of the Translational Research Pain Program, as well as the Comparative Pain Research and Education Center. Dr. Lascelles then, since completing his PhD training at Bristol in the UK, he has devoted his professional career to improving our ability to recognize and treat pain in animals. His research program develops methods to measure pain associated with spontaneous disease in animals and seeks to understand the underlying neurobiology with the goal of improving our understanding of how to control pain in animals, companion animals primarily, as well as facilitating analgesic development in human medicine. As I mentioned earlier, he's the director of the Comparative Pain Research and Education Center at NC State. He has authored over 270 peer-reviewed research papers and reviews, over 400 research abstracts, and approximately 30 book chapters. He's also the 2026 recipient of the American Association of Veterinary Medical Colleges, the AVMC Excellence in Research Award. Duncan, welcome. We're so happy you're here. And let's please give Duncan a warm welcome.
Thank you so much. Well, thank you very much for that very kind introduction. It's an absolute pleasure to be here. I've been having a great visit so far. And initially, please pass on my thanks to Dr. George Krienke for his support of this type of seminar series. I think it's fabulous getting veterinary and, let's call it human medicine, talking together and thinking together. With that, I'll get going. So the title here is From Poor to Patient, Dog to Human, if you like. That's really my approach to things, or what I'm going to present to you. And what I'm going to do is I'm going to give you an... Problem all around?
They can hear.
They can hear me. Okay, good. Yes. Yeah. What I'm going to do is I'm going to give you a kind of overview of my approach and ethos and this idea of using pets as models of human conditions, with obviously the benefit to pets themselves. I'm also going to take a bit of a deep dive into some data which is related to that. Hopefully it'll all come together and make sense. Before I get started, it's always important to acknowledge potential conflicts of interest. However, I'm actually not going to cover anything that any of these entities had anything to do with other than the funding for the work, which primarily has come from federal resources, and I'll double back to that at the end. Maybe just a little bit of a background on me. I think it's always, when you attend a seminar, you do sit there thinking, where did this person come from? So how did I get to here? Well, I went to vet school at Bristol. I also stayed on there to do a PhD, an internship, and then over to Cambridge University, where I trained in surgery as a small animal surgeon. Wanted a bit more training, so I went to Colorado State University, was lucky enough to get the fellowship in oncological surgery there, and then took up a faculty position at NC State. During my PhD, I was working on something called preemptive analgesia. So I'm now going to age myself. Started that in 1991. In 1989, a guy called Clifford Wolfe published a seminal paper in Nature basically saying that if you provide analgesics prior to surgery, you will eliminate all post-operative pain. It was a mouse model. It didn't quite work out like that, as I'll show you in a second. But that concept really embodied the idea of central plasticity. If you allow signals into the central nervous system, it alters and changes in a way that will produce pain later on. And so it was because I was interested in central plasticity that then, as I took my faculty position, I got into persistent pain states where central plasticity has been thought to play an important role. So these are some pictures, grainy, aren't they, from the early 1990s of me working on client-owned dogs and also in research rodents. And what I was working on was this idea, as I said, and the idea was that if there was injury, that would produce post-injury hypersensitivity, aka pain. That was a bit of a muddying of the waters. This post-injury hypersensitivity. And if you gave an analgesic post-injury, you'd get a dip in that. You know, the patient animals would feel better, but over time, post-injury hypersensitivity will decrease. Clifford Wolf suggested it was a rodent model that providing the analgesic before the injury would completely eliminate post-injury hypersensitivity. And he wasn't wrong. I think it was just misinterpreted as that's going to relate to pain. He measured hypersensitivity. The reality was that I found through my work was that if you provided analgesia prior to surgery, you could protect in some way the central nervous system and decrease post-injury hypersensitivity, make things better later on. And I think the reason I mention this is, yes, I was looking at preemptive analgesia, and that then led me, you know, when I was interviewing at NC State, led me to answer this question, now where? Well, I knew chronic pain had really not been touched in veterinary medicine. There was a lot to do, and so I was interested in central plasticity. That was clearly connected to chronic pain, so I said, well, this is what I want to be doing. Something which I had experienced during my PhD, but didn't realize for many years later, was that my PhD was comparative, and I was using client-owned dogs and research rodents. Paul Chambers had researched sheep and worked on farm-owned cows. Sue Lay was working on sheep out in the field and had researched rodents. That was the environment I was in. It was like totally normal. We have veterinary material we have access to, and we complement that with research animals. I thought that was normal. You know, years later, I realized that wasn't quite normal. You know, the two camps were really quite separated. So my overarching goal now, leaping forward a number of years, is to improve our understanding of how to control persistent pain in companion animals and facilitate analgesic development in human medicine and the discovery of relevant pain signaling mechanisms. So I very much I'm a veterinarian. I want to improve the life and welfare of animals, but at the same time, I completely believe that the material that we work on clinically is of relevance to human medicine. We just have to capture that. But you could ask, well, why do this work? You know there's a robust pain research program in universities all over the world. Why do we need to be, working hard to make something of the companion animals in veterinary medicine? And this is why. So the economic impact of persistent pain in the US has been quoted as being $560 billion a year, which is more than the economic impact each year of cancer, cardiovascular disease, and diabetes combined. Okay, now you can argue about the numbers, but the reality is the impact, the economic impact, hospitalization, medical services, lost work of persistent pain is huge, okay? And there's a lot of research. This is from Natalie Percy-Dessert and Andrew Rice's publication a few years ago. I added it in 2023, looking at the number of publications per year over time, and you can see there's an exponential increase. This is actually for neuropathic pain, but regardless, the rest of the pain field is like this. So there's a huge amount of basic science research going on. Okay, so big problem. lots of research. Overall, there's been a failure to develop new, novel, non-opioid analgesics for persistent pain states. Okay? How much of a failure? Well, this is what Jim Eisenach wrote recently. Despite generating a plethora of novel analgesic targets through all that basic research, pharmaceuticals for chronic pain treatment remain largely limited to the same drug classes as 40 years ago. He published that last year. Okay, so we're not doing that well, okay, in terms of producing novel analgesics. And, so maybe let's just start to sort of answer this question: where does translational pain research go wrong? The diagram here you see on the left of the slide kind of illustrates the translational research paradigm, okay? And so you start at the top there with drug discovery. Somehow you have to identify a target, a putative compound to look at. Then in your research model, you're looking at efficacy. So these are models of pain to see whether your putative therapeutic works. There's safety, which is mandated to be done in 2 different species, usually a rodent and a dog, sometimes rodent and non-human primates. Then you move into human clinical trials. Safety, phase 1. Phase 2 is where, at least in the pain field, you start to test efficacy. And this is where it goes wrong. The efficacy you see in induced rodent models doesn't translate to efficacy in human patients. And a lot of people have written about this. These are high-hitting pain researchers: Jeff Mogul, Frank Parecka, Yurtsky, Andrew Rice. These are names, if you're into pain research, you know and revere these demigods, okay? So they are talking about this. They are talking about why there's been that failure of translation. And I think maybe, that's a little bit depressing. So instead of where does preclinical translational research go wrong, why don't we ask, where could preclinical translational pain research benefit? Because we've actually learned a lot from the basic research. We know a lot about mechanisms and receptors and molecules and cellular function. That's useful information, no doubt about it. So instead of just throwing all that out and starting again, how could we enrich that process? How could we add to it in order to do better? And I think I just want to touch on 3 areas. They're big areas, but enhancements, 1, to the models, the pain state. Okay, so as I'll talk about later on, if I take a rodent and inject floor cleaner into its joint, it'll get arthritis. But the question is, how relevant is that to the arthritis that you and I suffer? The next thing is outcome measures used in the models, okay? And I'll leave that discussion for later on. That's a sort of a little hobby horse of mine. And then relevance of the target, okay? The target you're looking at has just got to be relevant. So let's go through these. Firstly, the models or the pain state. So I use rodent models. This is me injecting complete Freud's adjuvant into a rodent paw. This is one of my past graduate students, Ankita Gupta, injecting monoiodoacetate into a mouse's knee joint. Okay, I use these models because everyone else does, because I'm kind of expected to. Well, to be fair, it's a good way to start, but you have to ask the question: injecting monoiodoacetate that kills chondrocytes, how relevant is that to this 3, 4, 5 decades of degeneration of the joint and associated knee pain with all the other overlays, the psychological, the physiological, the nutritional, environmental? Our primary outcome measures are taken at 28 days in this mouse that looks the same as all the other mice. It's housed in a very sterile environment. So I think you have to ask, what is the relevance of these models? And that's where I posit that naturally occurring painful disease models, so the pets that we treat, may better reflect the complex genetic, environmental, temporal, so time-based, physiological and psychological influences present in humans. Okay? And you just start to think about it, you think, yeah, these are probably, better models. If you just look at OA, the fidelity is good. Biochemically, structurally, histologically, genomically, and molecularly, human, canine, feline, equine OA are similar. Okay? We have a bone expert in the room, so I have to be a little bit careful about what I say, but they are pretty similar, okay? There are some different etiologies and so on, but just look at the similarity here. It's not that different. One of those is a dog, one of those is, or was, my right hip joint up until December the 8th last year, when it's now been replaced. So similar. The burden is similar. These are some data that are generated recently with rheumatologists at UNC. Humans, pets, you actually don't need to understand what I'm showing here. The wheels look the same. These are the number of joints or joint sites that are affected with OA in these populations. 100 humans, 115 pet dogs, no joint sites affected, 1 joint site affected, 2 joint sites, 3, and so on. So the burden is similar, okay? And let me just go back, the disease is prevalent, which I think is important. You can use naturally occurring disease models to look at a problem, but if you're only seeing one of those every year, that's not going to be a very useful model. So you need to have access to the material. And I think, maybe I'm belaboring the point here, but this is my father shortly before he died. See, the video's not going to play that well. The video is very stilted, but that is his movement, okay? Stilted and uneven. And I think, if this little cat here, when you see the video playing ordinarily, this cat looks stilted and uneven. So just looking from the outside, you ask anyone on the street, does that mouse with the one injected joint look more similar to the person, or does the cat? It's the cat, okay? So there are some sort of obvious similarities across these. So then we come on to outcome measures, okay? So the models, I think, making the argument naturally occurring disease models are useful, have potential. Outcome measures. So this is a big thing. So this video, let's see if this video plays. This is an actuator pushing a little pin up onto a mouse's paw, and at some point the mouse will remove that paw. That's called the von Frey assay. This is electronic von Frey. You can have filaments that you apply. This is the bread and butter of pain research. Okay, you pick up any basic journal that's talking about measuring pain, and you'll have the von Frey assay in there. And if you read the language, people conflate sensitivity with pain. You'll hear people, eminent pain researchers, talk about the von Frey as a measure of pain, our pain assays. It's not. It's measuring sensitivity. Unless that paw is inflamed, in which case it's measuring hyperalgesia. But otherwise, it's measuring sensitivity. It's actually not measuring pain at all. And these reflex measures, mechanical, thermal, hot and cold, do not reflect affective or functional impact of pain. So it's a reflex measure. At its fundamental basis, it is a spinal cord mechanism, okay? Noxious stimulus, reflexive withdrawal. And we do the same thing in dogs. I don't think that video is going to play very well. So we do the same thing in dogs. And I think we've mislabeled this data. So these are quantitative sensory testing. We think it's something more fancy than von Frey. It's not. It's just sensitivity testing. And I think one of the things to remember is that mechanical sensitivity and other stimuli and sensitivity to other stimuli do not track that well with measures of pain. And this is something I think the pain field is grappling with. Pain drives central plasticity and central sensitivity, but they don't track that well. And you can have sensitivity but not have pain. You can have pain and not have as much sensitivity. And we've certainly shown that in the dog in some recent data. So how about measures then? So The bread and butter of basic research is these reflexive measures to external stimuli. We've also used those in the dog. What else could we do? Well, I think one way of looking at this is saying, what's important to people? You know, what dimensions are important to people with respect to pain? And you could draw a diagram like this. So chronic pain impacts sleep. Okay, most of you are too young to realize that, but there's a couple in here who will know that already, and the rest of you will learn it later. Chronic pain, certainly musculoskeletal pain, will impact movement. And therefore, if it's impact movement, the ability to perform the activities of daily living, how you function. We've talked a bit about somatosensory processing. Chronic pain negatively impacts cognitive function. Okay? Chronic pain will produce changes in the affective state, make you more anxious, more fearful. There's something called the fear of movement in relation to pain. These are dimensions that are important to people. And so now what I'm building up here is if you have a model of the painful state and you're looking to see whether your putative analgesic works, why not have measures that are important to people that are clinically relevant? And you know, this is where a lot of my work has been done. I'm not going to go through all of this, but these are just some image illustrations of the different outcome measures that other people have developed and we have built on, or we have really driven that development forward. You know, everything from caregiver questionnaires and validating those, obviously the physical exam. This functional linear modeling shows over a 24-hour period patterns of activity in dogs with varying levels of joint pain, the yellow being more joint pain. So you're starting to now be able to look at the impact of pain on patterns of activity. This is some cognitive testing going on. This is the cylinder task test. Obviously, force plates, posturography, pain, musculoskeletal pain will negatively impact your stability. So that's a good clinically relevant outcome measure. And so that's what a lot of my work has been over the last few decades, is developing these measures. And I think it's easy to think, okay, we've got a measure of gait. Force plates, that's our measure. Okay, we've got gait buttoned down. But if you think about gait and movement, sure, force plates for single limb use. You can also calculate symmetries, ratio of limb use. Getting a little bit more fancy here. If you want to measure temporospatial measures, then you're going to need something like a pressure-sensitive walkway, where you can look at the distance between foot placement, stride length, and so on and so forth. This is all related to gait. And what I'm trying to say here is, the more you think about it, the more you can get into some detail and develop outcome measures that reflect different impacts of pain. Posturography, we talked about that, how stable. Once we get into measuring the amount of activity, we're really thinking about using wearables. This is an Actical accelerometer. We've used a few others as well. And once you're looking at that, now instead of total movement in a day, a week, you can look at patterns of movement. You can also start to get a handle on sleep, with pets in the home environment. Again, that's relevant to humans. We can look at how individual activities are performed. Are they performed? How well are they performed? You just have to gather data at a higher acquisition rate. So instead of acquiring data at 30 hertz here with an epoch of 1 minute, we're maybe acquiring data at 200 hertz and keeping that richness of data. And you can actually, see how individual activities are performed. And my current interest is quality of movement or smoothness. Again, using wearables to get a measure, an objective measure on the smoothness of motion. Has anyone seen slow-mo video of a normal cat moving? No? Search it out on YouTube later, but they move like a drop of water through time and space. It's just so fluid and graceful, okay? Effortless and fluid. If you look at that, if that video of the cat had played, you would have seen that was stilted, uneven, jolting, okay? And that's what I think we can measure. And if you talk to humans, with osteoarthritis-associated pain. They look with envy at the young people who just spring up out of a chair and move fluidly across the room, because the way people with joint pain have to get up is, okay, you know what I'm talking about? You've got to get a run up.
Just had my knee replaced.
Yes, okay. You've got to get a run up, you've got to push yourself out the chair, and then you lurch forward, you feel pain, your muscles contract and stop, and then you kind of go forward again. And so that's a meaningful outcome, okay? If your putative analgesic fixes that, that's a good thing. It's not all easy work. This is trying to gather data in a cat. This cat would only walk down the walkway at a set velocity, plus or minus 0.2 meters per second squared acceleration for a can of tuna that was dragged down in front of it. So it's not easy work, but you know, if you understand pet behavior, you can develop these outcome measures. And so with those outcome measures, now we start to think about it, we have a model I've argued is relevant. Okay, that pain state is relevant on a temporal basis, a physiological, a psychological, environmental, comorbidities, it's relevant. And we can measure the impact of that pain with measures that are clinically relevant. So suddenly now, look at this paradigm. Instead of jumping from this area to human clinical trials, we can concurrently, while we're testing safety, run proof of concept studies in pets. Okay, so there's a putative analgesic. It's probably been in dogs for toxicity testing. We know its safety profile. Now we run relatively small proof of concept studies to help with that, what's in industry, what's called a go, no-go decision. Do we take this into human clinical trials or not? Okay, human clinical trials cost tens to hundreds of millions of dollars. Okay, and you don't know they failed until you get to the end. And so, you know, this is what I'm arguing, inserting our pets here to help with that process. And of course, the benefit is we learn about whether or not an IL-10 expressing plasmid works in dogs. We learn about whether a pan-TRAC inhibitor works in dogs, okay? So we gain that knowledge. The other area is right at the top, and this is what I'm going to focus the rest of the seminar on. And just think about it. You have a research program, and your team has come to you and said, okay, here's a target. We think this target's important, okay? And we have something that's going to interact with that target. And you may say, that's great, let's full steam ahead. Let me know how much you want me to write you a check for. We're going for this. What you should ask is, how did you determine that was a good target? Well, what are your data to show that's a good target? And they would probably, in most pharmaceutical companies, say, well, we took a rodent, we injected floor cleaner into its joint, and then 28 days later, we measured the changes in the spinal cord, and we found this receptor was upregulated. Okay? My question is that a relevant change? Relevant to the naturally occurring pain condition? Okay? Or is it just a change related to the injection of monoiodoacetate into the joint of a mouse? And that's where I think now the second part of this story is relevance to the target. And it is important, okay? This is a TRPV1 lineage neuron. This is some work Santosh Mishra, a colleague of mine, was involved with. There's a lot of redundancy, a lot of potential targets. And so out of all of this, you kind of want to know what is altered in the naturally occurring pain state. Rather than just say, well, we found, I can't even read this, ADORA3. We found ADORA, let's just block that, you know, because it's on a TRPV1 lineage neuron. If you're in the pain space, TRPV1 lineage neurons are really exciting. They're like the pain-transmitting neuron, okay? The question should be, is that target actually relevant? And so we get into discovery, and companion animals can be pain phenotyped. I've just told you that. All those outcome measures, you know, I hope it doesn't sound like I'm bragging, but I can take a client-owned dog and almost to the point of saying it has this number of units of pain. Once I've looked at it and measured a bunch of things, okay, we can pain phenotype them. Veterinarians have unprecedented access to tissue. Unbelievable access. Okay, I can't walk into your OR, but one of you guys could. You could walk into the OR of a colleague. You can say, oh, can I have some of that tissue? And you can walk out with it. No, literally, that's what we can do. Animals are euthanized. yes, for good reasons, for population control. Another, unprecedented access to tissues. Start to combine these things, you can then take those tissues and interrogate them for targets of interest. You know, is this actually altered in the disease state? Or in an unbiased way for discovery. Okay, so it's that combination of phenotyping. You know the phenotype, you know the problem. Now you've got tissues that may reflect that phenotype. What is actually altered? And this is not just my idea. Ewan St. John Smith at the University of Cambridge, his lab published this review a few years ago, encouraging the use of tissues actually from production animals for mechanistic studies, essentially saying, look, if we can do this in the mouse with mouse tissues, we can do it with sheep tissues, pig tissues, and so on. And we can learn a lot. And so the idea here is that own pets with painful disease, we can phenotype them, we have access to tissue, we can use that to discover novel relevant targets that we then go into rodent models with, figure out the mechanisms, and hopefully pull out something which is relevant to humans with the spin-off. It's going to be relevant to dogs. And so for the last part here, I just want to focus on some work I've been doing with Santosh Mishra, pictured over there, a great collaborator. And it's all related to artemin GF-alpha-3. So artemin is the ligand, GF-alpha-3 is a receptor, and that alters in a downstream fashion the transient receptor potential receptors, so TRP receptors, TRPV1, M8, A1, and so on. And so you can see here in this, this cartoon that we put into a recent review, artemin is binding to GF-alpha-3 and RET, and that interaction through downstream mechanisms will alter the sensitivity and activity of sensory nerves. And it was work, pilot work we did around artemin GF-alpha-3 that led to that R01, multi-PI R01, and then also led to some work, this is Mike Nolan, who heads up this R37, looking at the role of artemin in radiation-associated pain. Both of those, this was originally an R01, both of these R01s were started by taking tissues from dogs, okay? Here we just took tissue from irradiated areas in dogs, painful irradiated areas, and looked at that and found this artemin was up. And so, you know, just to double back, we can phenotype pets, we can measure how much pain they're in, we have this unprecedented access to tissue, you know, in surgery here, euthanized animals, we can have access to the central nervous system tissues. Here I'm looking at dorsal root ganglion, whipping it out, fixing it, evaluating it for our targets of interest or for discovery. And so the story here begins with Santosh Mishra. He arrived at NC State, I can't remember when, and I'm just meeting with him in his office. I mean, he's a neurobiologist. You know, he's a hardcore basic pain researcher. So I'm meeting with him, and he's interested in what I do. I said, well, I've got some tissues. I've got these dorsal root ganglion I've been collected from dogs. I know how much OA pain they're in. They're in the freezer, but I don't know what to do with them. You know, I'm kind of a clinician. I'm not a molecular biologist. And he said, well, we should look at some receptors. And then he quoted this work he was involved with. And he said, well, let's just pick some receptors. Let's see what's going on in these dorsal root ganglia, which houses the cell body of the sensory nerves. What's going on in here? What receptors are altered? So in his office, we selected a bunch of receptors. I have no idea how we decided which receptors, okay? I think it was sort of random. We weren't throwing darts at this, but you know, we had to look at TRPV1 and TRPM8 and TRPA1, and then for whatever reason, we chose the GF-alpha-3, the GF-alpha family, GF-alpha-3, GF-alpha-2, GF-alpha-1, and a few other receptors. And that initiated this stream of research looking at artemin and GF-alpha-3. So this was published, but essentially the first thing we did was gene expression, and I'm just showing you here GF-alpha-3 and TRPV1. These were dogs with unilateral hip OA. The other side was totally normal. Unilateral pain. So we can look at the ipsilateral dorsal root ganglia serving that painful limb versus the contralateral. And we're just showing you gene expression here for GF-alpha-3 significantly, quite dramatically higher in the ipsilateral than the contralateral. And just to, kind of make ourselves feel good, TRPV1, which we expected to be increased, sure, that was increased. Of course, that's not enough. That's just the gene. So how about the protein? Well, the protein's up as well. And so, the next thing we had to do was read up about GF-alpha-3 because we didn't know that much. So it turns out that the ligand for that is artemin. And so then, Santos said, well, how do we look at artemin? I said, well, I don't know, but I got some serum banked. Back to the freezer, we got serum from dogs, normal dogs, dogs with OA pain, all well phenotyped. Cats, healthy cats, cats with OA pain. At great expense, we purchased a few human samples. These were like $2,000 a piece, ridiculous. But we did that just to get, the human comparison, and sure enough, in the OA pain state, serum artemin appeared to be increased. So now we felt we were onto something. I also had some synovial fluid banked, and I looked at synovial fluid artemin levels versus symmetry index. You just have to trust me here. A more negative number means more greater lameness. And so you've got this negative correlation. As lameness decreases, synovial fluid artemin concentrations decrease. I won't leave that graph up for too long, because you'll notice the slope is driven by these 2 points. Regardless, we used that as preliminary data. So now we're starting to think, okay, artemin GF-alpha-3 axis is upregulated. And we were a little, we assumed that was driving pain, and that may not be true. We will see. But that axis, it was upregulated, is altered in dogs with naturally occurring OA pain. So it's worth taking a look at. The next thing we did was, again, thinking about the opportunity we have as surgeons. So when I haven't been in the clinic for a few years now, but when I was in the clinic, I loved doing total hip replacements. And what would I do? I would remount take the femoral head off, put it to one side just in case I needed it for a, graft, yes. And then I'd remount the acetabulum, I'd throw away the reams, get to the end of surgery, and that is almost perfect, isn't it, Wanda?
It is
almost perfect. Yeah, thank you. I get to the end of surgery, and I would then toss the femoral head and, pat myself on the back, job well done. What we started doing was collecting those tissues. The reaming of the acetabulum, so the fossa that the femoral head fits into, we're reaming out that material, collecting that. The femoral head, we saved those. As you're doing surgery, you kind of, or at least the way we approach it, is to decrease some of the excessive synovium joint capsule material. We keep that. We keep serum from these dogs. And now we keep hair, poop, tears, you name it, And then what we're able to do with that is now we can look in the naturally occurring disease at gene expression of artemin in the acetabular reams and the femoral head. Okay, and just, as a sort of checks and balances, we also looked at nerve growth factor in both of those areas. And so, pretty exciting to see the gene for artemin increased in that femoral head, in those femoral head tissues in the naturally occurring disease state. Now then, and this is all happening concurrently, we're back into the mouse models, okay, because we really want to find out more about this signaling mechanism, make some alterations, use knockout animals and so on and so forth to better understand this. And a lot of our work is in the monoiodoacetate model. If I fail to mention it later on, we don't assume this is clinically relevant. We're always checking, what are we finding in the model? Is that reflected in the naturally occurring disease state? But here you can see gene expression for artemin. And so now these are per mouse, saline-treated mice versus monoiodoacetate into the joint. So this is the arthritic state, okay? And we're looking at the tibia, proximal tibia, distal femur. Remember, this is the knee now, so it's a little bit different to the dog. That was the hip. And the synovium. So gene expression is increased. Again, checks and balances, nerve growth factor increased in the tibia as well. And then looking at the protein, not quite as clear a story, but certainly does appear to be tending towards that the protein in the arthritic state in these tissues, tibia, femur, and synovium, does appear to be increased. So now we had our findings in the dog, they're mirrored in this model. So, okay, let's move ahead and use this model to look in greater depth at things. And one of the questions we had is, well, we found artemin in the serum, so what are the consequences of that? Is that just something we can measure, or are there consequences to it? So Aditi recently, one of my graduate students, or shared graduate student with Santosh Mishra, ran this experiment here, where we're taking normal mice and giving them an intraperitoneal injection of artemin or saline. And then as we go out, you can see over there to 6 weeks, 42 days, we are measuring what she's calling in this diagram stimulus-evoked pain-like behavior assays. It's this sensitivity. So we're just measuring sensitivity. So the next graphs that come up, the top line, you'll see the saline-treated mice and how sensitive they are. The bottom line is showing you the artemin-treated mice, and the line is low because they're responding more quickly or at a lower threshold. Okay, and this should come up first. So just look at this. Hargreaves is heat. So the artemin-treated mice here out to 6 weeks, it's a single injection of artemin, are more sensitive to heat, more sensitive to cold, more sensitive to mechanical stimuli. One injection of artemin, 6 weeks later, these little mice are still more sensitive. That is sensitivity, it's not pain. And one of the questions we then asked was, well, how does that happen? Because artemin has a short half-life, it's definitely gone. What else is going on? Well, artemin is a neurotrophic factor. So at this point out here, we took paw tissue and stained for PGP 9.5. So we're staining for nerves, nerve density. And these graphs are showing you in the dermis and the epidermis, the innervation is greater. The density of innervation is greater in these little mice at 6 weeks compared to the saline-treated mice. So that's kind of cool, isn't it? That a single injection of artemin was driving a sort of a pan-body increase in innervation to peripheral tissues. And we've also verified this is true around the nape skin and other areas in the body. And this is some data just generated. So I work with Santosh Mishra. Javi Lopez Soto recently joined us. He's a neurobiologist, electrophysiologist. And that's my intro to saying I don't fully understand these data, but I'm going to take you through them as best I do. And so what we've done here is we're starting to answer this question, well, we've seen what artemin does systemically to nerve density. What does artemin do to individual neurons? So we culture mouse neurons, either with saline or with artemin. And what this diagram is showing is that after culturing for 48 hours with artemin, when you patch clamp these and look at their activity, the neurons that were cultured with artemin have this spontaneous spiking. Okay? Not only that, but their resting membrane potential as a population, so 30% of these have spontaneous spiking, all of them have an elevated resting membrane potential, which is not due to a leak in the membrane current. The rear base is altered. What you're seeing here is if you add current to those cells, the neurons cultured with saline really don't respond as you increase this current, 40 picoamps, 60 picoamps. But with the artemin cultured neurons, very quickly you start to see this massive spiking. And then this is a dose response curve, again looking at current, applied current versus action potentials. So in total, this is showing that artemin is sensitizing up, regulating the activity, the functional activity, not just some proteins going up or something, but the functional activity of these neurons. And these data are going to be presented at the Society for Neuroscience in the Triangle. But so this is fascinating, and I think I've got a picture of a rabbit hole in a moment, because very quickly you could start going down this rabbit hole. Okay, we found this, and what's the cofactor, what's this other receptor, what's the downstream mechanism, and so on and so forth. I think you have to step back sometimes, just say, well, is this relevant? And so this is some work that shows what we think is the relevance. So that is a little mouse sitting in what we call a pronograding capacitance meter. So we built this. You can see it's what's the word? Printed. At the back here, 2 little force plates. Each leg is on a little mini force plate, so we can measure how much weight and the difference from one side to the other. In the monoiodoacetate model, what you can see there, shown on the first part of this graph, is that in the arthritic state, there is a difference between the 2 hind limbs. It's not big, but if you're patient, you can measure that. So they're lame on the injected leg. And then if you sequester artemin versus saline, so the saline is the dotted line mice continue to be lame. If you sequester artemin with an off-the-shelf anti-artemin monoclonal antibody, MAB 1085, you then remove that lameness for a period of time. So sequestering artemin normalizes limb use. That's in the monoiodoacetate model. This is called the DMM model, which you basically go in and destabilize the medial meniscus. It's thought to be a more relevant model than that chemically induced arthritis. In male mice, you get this lameness. Okay, not in female. In male mice, you get this lameness. And again, a similar diagram here. So we're looking at the dotted line is the DMM mice with an anti-IgG control. They continue to be lame. The solid blue is the DMM mice with an anti-artemin MAB, same one, 1085. That lameness is removed. So now in 2 models of OA in mice, we've kind of shown proof of concept that sequestration of artemin is a potentially viable clinical approach. And we also, in the mouse model, remember in the dog, we found that the gene expression of GF-alpha-3 was upregulated. We've gone back into the MIA model and shown that upregulated gene expression of GF-alpha-3 in this model. So always back and forth with this work. This is some work here. Now we have 2 knockout lines for GF-alpha-3. And this is simply showing that with these reflexive assays, the knockout mice, so they have no GF-alpha-3. So they're probably producing artemin, but there's no GF-alpha-3. The knockout mice are still sensitive to heat, still sensitive to mechanical stimuli. The knockouts are in red, but they appear to be somewhat protected from sensitivity to cold. Okay, so it's like taking away the receptor for artemin partially decreases sensitivity to stimuli. It was protective against lameness to a large degree. Okay, this is the same thing, delta, lameness, more lame down here. And so you can see the knockout animals there. But then it turns out, this is where it gets interesting. So this is a different cohort of mice. Now in red are the GF-alpha-3 knockouts. They're sensitive in the arthritic state to heat, sensitive to mechanical stimuli. But when you give them an anti-artemin MAB, that is reversed. Okay, so artemin still appears to be playing a role in heat sensitivity, but not via the GF-alpha-3 receptor. Same thing over here with mechanical. Okay, and so this is now where it does get you have to start to think. Okay, what are the relevant parts of the signaling pathway? As we were doing this work, Regeneron published this, which basically said that in a mouse model, an anti-GF-alpha-3 monoclonal antibody was efficacious against evoked assays in mouse joint pain models, but not effective in a randomized placebo-controlled clinical trial in patients with osteoarthritis pain. Bit of a downer, if we're into this sort of research and this signaling system, to have a big pharmaceutical company publish this and say, no, doesn't work. But if you think about it, that's just the receptor, okay? That's not artemin. And if you remember this picture from earlier on, this was carefully drawn. Everyone believes artemin acts on GF-alpha-3 primarily, but it also is known to have activity through Syndecan, NCAM, and maybe some other GF-alpha-3 receptors. So you can imagine now in those little mice where taking out the receptor was not protective against sensitivity. Maybe that's because artemin was acting through one of these alternate receptors. And so, yeah, here's my rabbit hole picture. You know, it's very easy to get just so into this basic science. I'm always trying to step back and say, what is the relevance of it all and what next? Certainly, we need further characterization of the signaling mechanisms. We need to understand the detail. I'd like to know the time course of artemin expression. But at the same time, we're looking in the dog at what cells, tissues release artemin. We found it's upregulated, but from where? Because that might then allow us to target those cells. We want to do the same work we did that was done in the Soto Lopez lab using canine DRG, okay, and human DRG. Where are we going to get canine and DRG from? That's a question. Cadavers, yes, yeah, euthanized dogs. Okay, they're euthanized all the time. Pet dogs because of disease, dogs for population control. You've just got to get your stuff together so that you can grab those DRGs, and we can do exactly the same experiments. You know, is what we found in the mouse model also happening in dogs? And then we do need to, you know, proof of concept. I've shown you all that fancy work in mice, sequestering artemin, reduces lameness, reduces sensitivity. I think we need to proof of concept of that in the dog. And that's not easy because you've got to have a monoclonal antibody and enough of it to either treat systemically or locally. And when the genome is not fully annotated and no one really knows the sequence of artemin in the dog, that's a big hurdle. But you know, that's what we are up for. And so I think, you know, I'll just finish by saying companion animal models can contribute to translational research in three basic ways. A bridge. We can run studies, trials in pets with naturally occurring painful disease to test whether therapeutic has utility. We can also use these models just to better understand disease, etiology, risk factors, and we can use tissues from those animals to help with discovery and face validity. I'll finish it by acknowledging Avril Waterman-Pearson and the late Alex Livingston, who were my mentors during the PhD, and who, unbeknownst to me, set me off on this comparative path, because that was the lab environment I grew up in. There was just this wonderful mixture of production animals, pets from the clinic, research animals, all happening in the same place. I had great mentors. They were like chalk and cheese. Alex was absolutely lovely, just so supportive and kind. Avril was different. But great, because I think sometimes you need a bit of a stick, you know? You need someone to put a red line through what you've written and say, start again. And then I'll finish up by acknowledging a collaborative team here. Okay, this is what I call the TRIP team. None of these individuals is solely funded or mentored by me. And so my research model is one of collaboration. I have 3 multi-PI R01s. This is the work with Santosh Mishra. This is the work with Amanda Nelson at UNC. She's a rheumatologist. This is the work with Margaret Gruen, looking at the effect of pain on cognition and affect. These individuals are co-mentored, co-funded, co-supported across all of that, which I think is a really nice model. It sort of spreads the joy and spreads the pain, let's be honest. So I really want to acknowledge everyone who's been involved there. And we even have high school students and undergraduates in the lab as well. And with that, I will finish. Happy to take any questions if we have time for that.
I saw you did a little bit of work with females, but I also work with a lot of pregnant animals. Have you looked at all, and I know arthritis can be associated with pregnancy. I'm not going to pretend to be an expert, but I do know it's associated with it. Have you looked at all into pregnant animals? And have you looked more into the differentiations between male and female? Because the one graph you did show, there was no differences in female, but females also get arthritis. So
yeah, well, actually, it's more important than that. So yeah, there are no differences in that model, and that's pretty well known. And so going forward, we're going to use a PMX, partial meniscectomy model, where females do develop OA and pain. But that's really important because the archetypal chronic pain sufferer, human pain sufferer, is female. 60-70% of chronic pain sufferers are female. And so it's really important to make sure that you have those, you understand the sex hormone influences for sure. I've spent, 59 minutes talking about how good the dog model is. All of these dogs are desexed. And so I think that's something we also have to admit and think about as we move forward. What is that influence on OA? Maybe it drives it, makes it worse. And is that relevant to the human population we're looking to manage?
You kind of answered this question. I'm still curious a little bit about what's the similarity between species of the gene that controls, the Archimedean GFR.
Yeah, great question. So Alonso's question is, what is the homology for the Archimedean gene across species? It's round about 70 to 85%, something like that. I say round about, and with a little bit of hesitation, because I don't think we know fully what the sequence is in dogs, and that's going to be a bit of a hurdle for us to get over. But if you look at mouse, rat, naked mole rat, it's in that realm, 70 to 85%. So it's not bad.
This question on Zoom from Dr. Laura Stone. What are the most common pain conditions in companion animals, and how does that compare to human?
That's a great question. I'm not sure, so hi Laura, I'm not sure I can fully answer that in great detail, but I think certainly the pain conditions that I start to think of is, osteoarthritis pain for sure. Companion animals do not suffer very much from rheumatoid arthritis as far as we know, so that's not going to match up to that common problem in humans. Cystitis pain I think is common enough in companion animals that there's the opportunity there to develop that as a model. Cancer treatment-associated pain, whether it's radiation-associated pain, chemotherapy-induced peripheral neuropathy, I think those are common things, even if they're not really recognized in companion animals. Cancer-associated pain, osteosarcoma, lovely model, beautiful model. I mean, the oncologists have really been running with that for years, but no one's comprehensively done work in that as a pain model. But that, I think, is an area that's ripe for research. Bone pain is very difficult to treat in humans. And so, I'll stop there, but you could go on. I won't stop there. Intervertebral disc disease. That is desperately common in dogs. I think we need to do a lot of work to define the outcome measures and try and define where's the pain localized. But that's a great model of low back pain, which is the most common pain condition in humans. So I think there's a lot of opportunity. Yes.
I don't know anything about the scientific basis of this, but I've always had pointers hunting dogs, and I think of them as very stoic animals. So I wonder what scientifically is out there about how animals manage their pain versus humans who maybe don't have that same stoicness.
No, I think that's a great point, and that's something that we are aware of, and we've been doing some research in this area, and I think you could look at it from either end. So one end is the psychological aspect. So pointers maybe have a psyche where they are going to cope with pain, manage pain, not show it, keep going. I'm not saying they're not feeling it, but I think there are some behavioral manifestations of how they respond to pain. Okay, I'm not certain it's less pain. I think it's how they respond. At the other end, you can say, well, are there fundamental differences in pain processing across the different breeds? And that's fascinating. So Margaret Gruen, who I collaborate with, she sent out a survey to, I think, 1,000 veterinarians, 1,000 owners, asking them to rate breeds for sensitivity to pain. And the owners all agreed on rankings. The veterinarians all agreed on rankings. Veterinarians and owners didn't agree. They were mismatched, okay? And so then you have to say, well, what's the truth? So we then ran a study where we took 10 different breeds and we did the QST testing to look at pain sensitivity, if you like, or sensitivity to noxious stimuli. And there are some breed differences. They're not huge, but there are some breed differences. And it's not just small breed, large breed. Some large breeds were as sensitive as some small breeds, and some small breeds that were not that sensitive. So there are breed differences, but though the breed differences we found don't explain what the veterinarians thought or the owners thought. So going full circle, we think that what people think about stoicism and sensitivity in breeds is based on stereotypes, the hidden curriculum in veterinary medicine. I mean, I have used the words, oh, it's just a vocal husky. That's a bias, you know? And the people who are listening to me in clinic then catch on to, well, I want to be like a big vet, so I'm going to talk about huskies like that, you know, or the pit bull that doesn't feel pain, you know. And so I think there are all sorts of biases that have crept into our perceptions. We really don't know much about reality. Was that a vague enough question? Answer?
How do you account for that then in your work?
Yeah, no, I think I thought you might go on and ask that. So I think the two things. One is in clinical trials, we need to be cognizant of it. I think there's so much other variation and factors that cause and noise in the data that I don't think breed influence is a big thing. Another way of looking at things would be to say, well, let's do some work in just a single breed, you know, or certain breeds and compare carefully.
Great. Well, thank you, Dr. Lascelles, for an engaging seminar, and thank you all for coming.